view and took them all together. CDC is being highlighted because it was mentioned in the legislation specifically. So in that light, I've asked Dr. Zaafran, because he is on the regulator side of things, but he also understands from an anesthesiology perspective the importance of acute and chronic pain, to present those, though he was not on the subcommittee one deliberating it, so that it is neutral. And we really just want to send a message of what we think needs to be improved and updated here in 2018 from the lessons learned from the last few years, taking into account those that are most important, which is the public and our public comments and our patients, and remaining in a patient-centered fashion. So with that, I'm going to ask him to, if you could either get up and state it, or you could just state it from right here.
I have it in front of me also.
Okay.
So I just wanted to emphasize that, number one, this was in many instances a reinforcement of a lot of the guidelines that were there, maybe a clarification of some of the gaps that were perceived that were there, and the importance of making sure that the message that was given to providers and to patients out there was consistent with all the recommendations that we had. So as such, the key recommendations that we put out there, and it's not inclusive of everything that we have, but these are the main ones, was number one, to conduct clinical studies or complete systematic reviews to identify which subpopulation of patients with different chronic pain conditions may be appropriate for long-term opioid treatment in conjunction with the various non-opioid modalities. Again, we're trying to state it in a very clear fashion. It may not necessarily conflict with the original guidelines, but I think it's an attempt to make sure that it's very clear what the intent is. The second part is to develop guidelines for tapering and dose escalation for subpopulations of patients with chronic pain conditions that includes consideration of their comorbidities. Again, with the understanding that tapering or escalation is not a one-size-fits-all. It depends on the patient, it depends on their treatment plan, and it's got to be thought of as such. The third is that once a stable dose is established for at least 2 months, avoid increases in dose until the patient is reevaluated for the underlying causes of the elevated pain. And in many other places, we talked about making sure that there's compensation for the patient to be seen by a physician for an adequate amount of time, to be reevaluated and reassessed, and to make sure that if there needs to be a change, that's properly established. The fourth one is to discourage the use of arbitrarily defined MMEs and daily dosing limits on chronic pain management, and utilize established and measurable goals such as functionality, activities of daily living, and quality of life measures. Again, we understand that there are patients who are opioid naive, that a small amount of MMEs may not necessarily make sense to them. We also know that there are chronic pain patients who, again, may have been on magnitudes of MMEs that is appropriate for them. And we want to make sure that that is looked at from a functionality standpoint, from an activities of daily living standpoint, from a quality of life standpoint, and assessing it and not having some arbitrary number that's out there that may confuse a lot of providers and clinicians. And the final one is to undertake opioid tapering or escalation with a thorough assessment of the risk-benefit ratio. This should be done in collaboration with the patient whenever possible. Again, we want to make sure that the patient is involved in the decision-making process here, especially when it comes to escalation and to tapering. If the patient's not involved in that decision-making process, chances are it's not going to succeed. So we wanted to make sure that that was part of the recommendation that was there.
More details they've been passed around for the last couple of weeks, so I think all of you have them, but this is for the public to see what the key recommendations are. And once again, it's to understand the individual differences that exist with underlying medical issues, differences that exist in metabolism, rapid and slow metabolizers, differences that exist in terms of what goals are there, and ultimately clinical decision-making at the end of the day with the person who is taking care of the patient and the patient themselves. So with that, we are going to, I think we are very close to having Senator Cassidy here. Oh, yes. Oh, okay, good. I get to do my reflections. That's where you guys just get to hear me talk. So we're just going to review, basically. Okay, thank you. I was just looking through my notes actually from the whole day, and so we've had a lot today. And I just want to first start off by telling you all that when I was reviewing what we've done this last summer, I mean, it was May 30th and 31st that we all just got to know each other. And I know the application process was long and prolonged, and there were many regulations and rules, and, you know, sometimes it's not obvious, and it was clearly not obvious to me because it wasn't that long ago that I was outside the federal capacity and then I was here. But we suddenly came here, and there's been a lot of rules, and there's emails that go around. Our intent at all times was to protect the integrity of this very important task force, and that people on this task force bring amazing perspectives. People in private have shared with me their great concerns about taking care of this patient, a very vulnerable community at large. As we can see, it's millions of people, 20 million alone at chronic high impact pain, and then 50 million or more, depending on the source, who have pain otherwise.